We move voluntarily to feel good, we move to get stronger, we move for peace of mind, and some of us move involuntarily, repeatedly. Hello and welcome to Tick Fit the podcast, a podcast where we discuss all things movement in both the exercise sphere and in life with Tourette Syndrome. This is a platform to discuss Tourette Syndrome and its effects on our bodies. We'll speak with movement professionals where we can advocate and educate about Tourette Syndrome, while the Tourette community can benefit from the expertise of these individuals. We'll also speak with professionals about Tourette syndrome and other tic disorders. I'm your host, Raquel Cunningham, and I've been on a quest for the past 2 decades to discover the connection between movement, exercise, and our ticking muscles. This is not meant to diagnose or treat Tourette syndrome. There is no cure for Tourette syndrome. We are here to advocate and educate about Tourette through conversation, and anything in this podcast is for informational purposes only. Please always consult with your doctor before beginning any exercise program to make sure that it's right for you. Hello, everybody. Hey, movers. I'm super excited today. We have Robert Linkul with us today, and he has a lot of letters behind his name. He has a master's degree in personal training sports science, a bachelor's in kinesiology, certified strength and conditioning specialist with distinction. He is a certified personal trainer, also with distinction, and he created Training the Older Adult. He is, I can keep going, an NSCA fellowship member, an NSCA personal trainer board representative. Yeah, that's a lot. We have a very educated individual with us here. Hey, Robert.
Hi, how are you? Good to see you. Thank you for having me. Happy to be here.
Yeah, super excited to get into this. First and foremost, Tourette syndrome is still kind of thought of as a youth syndrome. And I mean, it's been around for 100 years. We have 40 years worth of research on this, and that population gets older. So there's a very real concern for wear and tear on the body of doing these repetitive motions. And I'm excited to hear your specialty. So can you explain a little bit about your background and how Training the Older Adult came to be?
Absolutely. Yeah. So I started out in the industry, 1999, 2000, right out of high school. I started training. And I think with a lot of coaches, their interest is with training athletes. And I was an athlete. I was an NCAA hammer thrower. I was sponsored by Reebok after college, trying to make the Olympic team, and just experienced all these injuries. I continued to hurt myself over and over again. I was a personal trainer on the side, working my way through school. And as I continued to get injured, I wrote about my injuries. I published some content. I made some videos, and more clientele that experienced those same injuries started coming to me because my body was so banged up and because I was basically experiencing excessive use, wear and tear injuries. That's more of an older adult type of injury that you would get. And so my demographic started to kind of shift towards older populations. Then I had some pretty serious health concerns that came about. I was training and started coughing up blood one day and went and got an x-ray, and have had this happen a million times. Always had chest issues and breathing, and I would get pleurisy a couple of times a year, and just always had these issues, and have had 8 or 10 different x-rays in the past. And so I do this x-ray and I get ready to leave, and it's usually 2 or 3 days you'd hear something, and then I get a phone call before I leave the parking lot, and they're like, come back right now. And so I get back in there, and they're like, there's a tumor, covering 70% of your left lung, and it's cancerous. Like, we're gonna have to remove this. So I had one of my ribs removed and 2 more broken, and my entire left lobe taken out, about 80% of my entire lobe taken out, and with a carcinoid tumor, and had to rehabilitate that entire thing. Through that process, I had a secondary scan, and they found another carcinoid tumor in my thyroid and my parathyroid. So I had that entire thing, plus a chunk of my sternocleidomastoid taken out, and had multiple years of thyroid levels and fluctuations and 0 testosterone, all of this. My hips continued to wear away. I had back surgery. I had arthroscopies on both hips, total hip replacements on both hips. My left one dislocated 7 times in 24 hours until they're like, this thing's just not going to take. We got to give you a full revision. So I've had 3 hip replacements, all before the age of 36. A hernia repair, carpal tunnel, a ganglion cyst, remove all this stuff. All of this, I don't tell you to impress you, but to impress upon you, I'll steal an Alan Cosgrove line there, how life is not happening to us. It kind of happens for us. That's a Tony Robbins line. But I embody that, and I really take that serious, that God has put me in a position to experience all of these things. And with the mindset I have, with this obsession for research and finding the ways to rehabilitate and get people back, I had firsthand experience that most 70, 80-year-olds have. I had in my 30s, and I got to rehabilitate myself and then take those strategies and start to plug them into my clients, and they've worked really, really well. And we showcased that over the last couple of years, and other trainers have come and said, how did you do that? And what did you do? And when did you know? And what assessment did you use? And so we started to do some webinars and do some live clinics. And next thing you know, TOA was born. And we've had, it started in 2016. So almost 10 years now of educating other coaches. I would say we have 600 or 700 TOA certified trainers out there in the world. We've got over 1,000 FitBody TOA Forever coaches. I work with FitBody Bootcamp in their older adult program. I'm their director of education as well. And I've been doing that for the last 3 years for them. And so we've got a whole nother group of coaches working with the 55 and up demographic there. And same thing, I basically get to go through all this research and disseminate it out to everybody. And we continue to do that to the best of our ability every day to combat and battle a disease called sarcopenia. And sarcopenia is the loss of muscle mass and function in deconditioned aging bodies. The regular definition is just the loss of muscle mass and function, period. But we add in the deconditioned body part, because those that do condition their bodies, that resist and strain one up, they don't get sarcopenia. Just to say like, well, you're 70, you've got it now. That's not the case. Those that brush their teeth don't get gum disease. Those that build muscle mass don't get sarcopenia. That build muscle mass and bone density don't get osteoporosis, right? So we've seen that aging populations that really keep themselves strong and conditioned, have good minds, have good bodies, have muscular abilities, they have athletic abilities, and they can continue to do stuff into their 70th and 70 and 80 years of age and decades of life. This is how it should be. This is how people should age. But our U.S. population, we have the largest collection of older, deconditioned, sick individuals on the planet. And that's become a huge personal battle of mine, is to help combat that. And ultimately that brought me to you, or you to me, or whatnot, and how we kind of came here today. So that was a very long rant, but that gives you a pretty, as quick as I could, a pretty quick insight as to who I am, what we do, and why we do it.
But it's unbelievable what you've gone through all before 36, and a true, double-sided approach to personal experience and education, and this mission that you're on to help the older population keep living their best quality life, and to prevent the things that are preventable, and how to handle the things that are not preventable that happen, as life happens for us. As you say, there's still choices and things that we can do to keep moving forward. Absolutely. I think it's incredible what you're doing.
Thank you. I appreciate it. I appreciate the support. And I know you've shared some of our stuff out in the past and helped spread the word. Our biggest concern to go with sarcopenia is fall risk and the damage done in falls. And that's really a whole nother area of education that we have to bring in with folks, is showcasing to them how important it is that they can get up and down off the floor, and then they could survive a fall. And, we'll have clients that'll come in for their initial assessment, and we'll say, can you get up and down off the ground? And they'll go, I don't know. I haven't tried in 30 years, 40 years, like something like that. And it seems silly to me. I'm on the ground multiple times a day. I have kids, I have a dog, I exercise, I do yard work. I'm up and down all the time. But my parents, if I were to ask my mom, when was the last time you were on the floor? I think the last time I asked her, she was like, Nixon was in office. That was 40 years ago. You know what I mean? So it's that kind of stuff. We just don't, because we speak fitness, we're in fitness.
Right.
Those that don't speak that, it's completely foreign. And we can't just make those expectations that they're going to just get it and be like, oh yeah, I'm in. We've got to bring the education and show them, here's what's going to happen. If you're over the age of 70 and you fall down and you have any kind of catastrophic break, your ankle, your knee, femur, your hip, the femoral neck, your pelvis, anywhere in your lower back, your forearm, your clavicle. If any of those break, you're over the age of 70, estimations and statistically in the next 6 months, you're dead. You do not come back from this.
Statistically speaking,
Statistically
right?
speaking. So 30% of people will recover from that. And if they experience another one, they're dead in like 3 months. People over the age of 50, if you fall and have a catastrophic break, you will not regain the ability you had prior to that fall. Upwards of 90% of the folks will not do that. And it's like, what abilities did they have prior to that at age 50? They may already be really deconditioned. And you're like, let's just get back to like a level D, right? Let alone a C, a B, or an A. Like, let's just get back to where we were. We can't even get there. It's that
Right.
severe. So
It's really intense.
yeah, it's really intense. And that's where a lot of the passion comes from. My family members and other family members, my in-laws, etc., grandparents. I've seen all this, and it's definitely a challenge that's very personal, near and dear to me. As we've witnessed individuals that have not successfully recovered from this, and then part of the 30% that have, a little bit of the miracle. My dad, fortunately, was one of them, and I got to be his coach for the final 3 years of his life and help him recover from 2 major falls and 2 broken hips and a knee replacement and 150 pounds of fat loss and being anemic and having kidney failure and 3 heart attacks. And he was still smiling up to the moment that he died. And that is by near moments of observing him and seeing him go through that experience and then pass. I knew this mission in life is anyone I'm working with, that's their dad, that's their mom, like that. What I got the last 3 years with my dad, I want to be able to help other people deliver that and have those times with their family members. And I wish I had more with him. But I feel blessed that I got that. He was not on a good path. He was in that 6-month window. And the potential, I would guess he had a 98% chance of dying in that 6 months. And the 2% chance he'd survive, he did. And that's why I kind of consider that a little mini miracle there of having my dad around for another 3 years. But we got to train together every week. And I watched him slowly just get better and better and stronger and more capable and cognitively. And I know I'm rambling, but he was my best friend. He was my best man. He was my ultimate hero, and still a huge, motivating, powerful part of my life, even though he's been gone for 2 years. And anybody
What a
I get
gift
to work
that
with,
is.
yeah, this is
What a gift
this is
that
why I
is.
do it.
And man, Robert, your passion fits right in with the Tourette community. It does, because I think everybody in the Tourette world is an amazing community and driven by passion and compassion.
Hmm.
And I'm really excited that I get to let this community know about you.
And I'm excited to learn, because I've got, I got a few things that I've researched and a few things where our strategies very much so overlap, and I'm excited to talk about those. But I'm still very, very new to this field and to this particular. You do call it a disease, right?
We call it a syndrome. It is a
Syndrome.
neurological
Okay,
syndrome.
So
Yeah.
that syndrome is very oh, we're getting hi guys, I'm live.
I
I'm
thought
live
one of my
recording.
kids was going to
No
walk
problem.
in a minute
No
ago.
problem. All good. Sorry.
I heard one of mine running down the hallway too. I was waiting for
It's all good. They're heading out to their play date. So they always come out and say goodbye to me before they go. So I do a bunch of mentoring calls as well. So I think they
Awesome.
thought I was on with another coach just doing, and they
That's
always
all
know
good.
they can just come out and go. So sorry about that.
Don't be at all. Again, you
Okay,
might hear my
so-
dog snoring in the back, or you might hear
Okay,
one of my
good.
kids coming in too. So
So it's a syndrome.
Yep.
So I'm excited to learn
it is a syndrome.
that and more with this, because I definitely think resistance training itself can be a huge benefit, and I'm excited to share some of the research on that.
Awesome. So basically, it's the podcast came about to try to create these conversations and speak the language of movement.
Mhm.
So tics are a syndrome, or I'm sorry, tics are a symptom of this neurological syndrome. There's a lot else going on in the brain that, there's a lot of research that they're advancing, and it's a growing field, and everybody's still trying to figure out what's going on in the Tourette brain. But again, these are symptoms. So DSM-5 is 2 motor tics, 1 vocal tic present for a year. And so what I find interesting is I really hone in on some of the breath stuff too, because breath can be like a physical tic, this physical squeezing of the abdomen, but it's also involved in the vocal tic too. And all this other research coming out about breath work and parasympathetic state. And there's very, very few studies on resistance training with Tourette syndrome. There's very few. And by and large, it's mostly cardiovascular. So the premier treatment for the symptom of Tourette is called CBIT, Cognitive Behavioral Intervention for Tics. And there's some awareness training. They're basically looking at this premonitory urge that happens before the tic. And you have to learn when that happens for yourself, what triggers your tics, if you can identify that.
Okay.
And what CBIT does is they look at finding a competing response, which looks at doing the opposite motion of that tic and holding it for a minute. And this is where, like, great, we can tell you what those muscles are. And here's like a whole slew of, educated guesses of what a competing response for that person might be.
So give me an example. So what is a fairly common tic?
Head tics.
Head tics, like a twitch or a turn?
Yes, very much so. They're always very described as like jerky motions. They're not always fast. By and large, I would say the majority of them are concentric, fast contractions. Some are eccentric, some you might like stretch here, but it depends on where that's happening. There's a lot of different head rotational movements.
Gotcha.
And then you got to kind of dig in with the person. Where is this sensation to tic coming from? Is it to get a stretch in this SCM here, or is it to feel a pinch behind the neck here?
So you're seeking a feeling by performing the tic that then relieves the stimulus of wanting to perform the tic, the buildup of it. Because you start to feel the buildup. Okay. So if your tic is to laterally turn your head, you're saying as that sensation to turn my head to the left occurs, I would counter it by turning my head to the right and holding it there for 30 seconds to a minute. Is that what you said?
Yes.
And that would alleviate my demand to want to turn and tick my head to the left.
They have discovered that is the premier treatment.
Gotcha. So basically it's an agonist antagonist kind of approach of fatiguing the opposite side.
Bingo again.
Wow.
So, but how do we study this and how do we get more? So tics can also be simple or they can be complex. A simple tic would be that just the one directional turn where we can isolate, okay, it's rotation to the left, rotation to the right, or they can be more complex. Maybe it's a rotation and your knee drives up and your shoulders I get all bumbled up when I get excited, protracting and internally rotating with the head going, with the knee going. So it really becomes this body puzzle.
Okay. Wow.
Right. And so as this population ages with these, we can think of the wear and tear and where we might be able to help at least get out of pain.
Yeah.
Right. Above all,
so these are painful. These are painful as well for them to perform.
They're very painful. Sometimes
because
pain
just
can be
overuse of doing it over and over again. Okay.
Correct.
Very good.
Correct.
Good. Okay.
So interesting. I want to go back to a question for you. When you were dealing with everything that you were in your life, where did you get all of these certifications? Did that happen after all of these life events? Did it happen during?
When I was going through my undergrad for kinesiology and strength and conditioning and human performance, I continued to ask my coaches and my teachers, how can I learn more about this? How can I learn more about that? And I had a couple of teachers that, this was 2003, 2004. So the internet's there, but it's not the amazing search engine that we have now.
Right.
And they would say, well, you could try this one website, or you could try a magazine or something like that. And then I went to my Olympic weightlifting coach that was helping me. And he goes, have you heard of the NSCA, the National Strength and Conditioning Association? They have a monthly journal that they produce that is basically anyone in the United States that wants to submit their thesis as they are graduating. If it's written properly, they'll publish it and share that information out based on the research you've done. They'll share it out and let people read it. And I was like, man, that sounds great. Like, that's exactly what I'm looking for. And so I joined the NSCA, and every month I got this giant blue journal, the Strength and Conditioning Research Journal. And it would have 20 to 30 thesis research articles in there. And then they also had the strength and conditioning a general strength and conditioning publication that was a thesis type article written in a way that was more consumable, like almost like an abstract, but with greater detail. They would include images or pictures of how we do these drills or what the lift looks like through these 4 different phases of action. and it would give greater detail of one particular part of a research study or one area of aspect. And so that pursuit with the NSCA led me to, I'm always going to have an avenue to find and obtain research and answers from this organization. And no one else was really doing that. ACSM does, but it's very medical focused. The NSCA was all strength and conditioning, and that's exactly what I wanted. So I went, well, I want to become a CSCS, one of their certified strength and conditioning specialists. And I also am a personal trainer, so I want to represent that profession well. So I want to obtain that cert. Outside of that, to be an efficient strength and conditioning coach, you need to know the Olympic lifts well. So I went to USAW and I got my sports performance coach and my weightlifting coach cert from them. And then outside of that, as I continued into the industry, I just found other areas that I was either lacking in or had extreme interest in, either one, because I wanted to be the most well-rounded coach that I could be. And so I would go and take a certification on training women through pregnancy. And I had clients that did that. And then I would go and find a doctor who was doing a public speaking on recovering people after their back surgeries. And I'd stay there for 3 hours and learn about that and ask them questions, and just continued to try to hone my skills. Where the analogy I like to use is, if I'm going to sit at a table with an expert like you that knows her field of genius, her area of expertise with Tourette syndrome, I want to at least be able to stay at this table and have a discussion with you. You're the expert, but I want to be able to understand at least the base minimum and have us speak a language where I could contribute something that would help you in your level of expertise, and vice versa. But the rest of that table is ballet and older adults and recovering from cancer and baseball and wrestling and jiu-jitsu and football and older pops post-fall and whatever it is. Everyone's got that. And so I'm like, all right, where am I lacking? And I just made this giant chart of info, and I'm like, I got to learn something about all these. And over years, now decades of doing that, I feel like I have a pretty decent understanding. I'm like a Swiss Army knife in effect. Like, I could do a little bit of all this, but I've got this one area of training older people to be stronger that I'm really passionate about, and where I feel like is my zone of genius. Like, that's the spot where when someone says, like, what do you know the most about? What were you put here to do? It's that. But I also want to just be able to be a decent representative and contributor to all the other areas within our field that overlap as well. And so there's so cool. A constant to try to fill that in,
That's basically how I became a trainer too. I've been training for 15 years, and I just kept chasing movement, thinking, how can Pilates help somebody with Tourette's? Okay, the fluidity and the breath component. How can kettlebells help somebody? The eccentric, rhythmical nature of it. And I want to get into some eccentric training conversations with you too.
Yeah, I got a couple of research studies to cite for you on that.
Awesome. But yeah, that's kind of how I kept building my pregnancy and postpartum athleticism as well. And just kept chasing movement. But I do think my niche is neuromuscular reeducation. It's really figuring out these different body compensation patterns and then helping somebody build back to their optimal, minimal pain life.
And correct me if I'm wrong, but that is our primary concern with individuals with Tourette's, is that the pain, discomfort that comes along with that tic is changing their quality of life so much that the tic is kind of the focus of their life, and they're not living at a quality because this is such a problem. Is that
yes,
a decent
it is a disability.
Yes. Okay.
It is classified as a disability.
Okay.
And joints can sublux as part of the tic. Like, just because it hurts doesn't mean that the tic stops.
Yeah.
So as years of these movement patterns happen, you have somebody in their 60s and 70s that's been ticking this way for a long time. I think a good conversation for us to have would be, let's say you have somebody who's in their late 60s who's had scoliosis. Let's call it a functional scoliosis. Sure. How do you deal with training asymmetries in the aging population? We're all asymmetrical, we know that, but especially with the aging population, how do you train asymmetries?
That's actually two questions in one, because an asymmetry versus scoliosis are two different areas of focus for me. And what I mean by that is if someone comes to me and they have scoliosis that has created the asymmetry and they're over age 50, we're not going to correct it. You're either going to correct scoliosis early intervention in youth, typically prepubescent, where you're braced, or surgical intervention, whatever it is, to try to correct. Beyond the setting of bone, ladies 24, gentlemen 28, 29, around in there, beyond that, you're really not going to be able to fix that without pure surgical intervention. So if you get to 50 and you have functioning scoliosis, I'm going to continue to lift you and train you just like anybody else your age that doesn't have scoliosis. It's just not going to look the same. I want this beautiful, straight lined lower back when you're deadlifting, and I want your kettlebell swings to be in perfect alignment, and I want you in a nice vertical position when you're overhead pressing bilateral, nice and even. That's with a fairly symmetrical individual, I would seek that. But we're working with something different here. The structure, the foundation which the house is built on, has a curvature to it. But it was done so in a way where not just one or two or three of the pieces that build this whole thing up, the vertebrae, the disc, and the nerves running through it, all of them have curved and manipulated together. So they've kind of grown with one piece, which means they're still highly functional, which means they're prepared to take any kind of damage, stress, load, axial, vertically loading pressure on top of the body, or anywhere else. The body is capable of handling that because it's grown into the ability to manage it. Where someone that maybe is a baseball pitcher who has thrown with their left foot forward and their right arm finished and created an asymmetry there can be corrected out of that, because that was movement based, not necessarily born with in terms like a scoliosis would be. So it's very common for coaches to see someone with scoliosis and go, oh, we're not going to deadlift them, that's going to hurt their back, and we're not going to overhead press, that's going to bother that. No, man, they are good. They are okay to go as long as they can tolerate and whatnot. You're actually doing them more benefit to their bones and their musculature by stressing them under heavier load lifting than if you didn't. If you tried to just do corrective exercise, which you can't fix, you could maybe make it 8 to 10% better, maybe through muscular engagement. But that's after age 50, that's not worth. What's most worth it is getting them and keeping them really, really strong and bone dense. And so that would be my approach to more or less answer your question. That would be my approach with this, is you have a functioning disability that you are working with. And that's the same that kind of connects us here is, as I've worked with people with Parkinson's disease, that the tics that they experience with the shaking hand, shaking of the face, shaking of a foot or whatnot, the neurological response to that does get fatigued and exhausted, similar to individuals with Tourette syndrome, in how they've done a couple of different studies now, one with neuromuscular intervention via resistance training and one with high intensity interval training. One was done with a ski erg, 8 minutes in the morning, 8 minutes at noon, and 8 minutes in the evening. And individuals with Tourette syndrome saw their tics reduce, don't quote me, but I want to say it was like 37 to 40% throughout the day when they would do these 8-minute intervals 3 times through the day.
Was that with Tourette syndrome or Parkinson's?
With Tourette's, yeah, with Tourette's. And then the resistance training one was done with Parkinson's disease, where they would have them do swings or squat and presses or clean and press or a snatch, something that was a full body lift. And they'd have them do like 3 sets of 10 or 4 sets of 8, like something that kind of got them to a stress neurological response, but it didn't take a ton of time, 4 or 5 minutes. And they would do that morning, afternoon, and night. And very similar, their shaking responses would be reduced. And so the more often that we've seen individuals with Parkinson's disease exercise on a daily basis, even if they do spread out a walk, a high stimulus walk of hills or whatnot in the morning and lifting in the afternoon, playing pickleball in the morning, going for a bike ride in the afternoon, golfing in the morning, going for a lift in the afternoon, anything of activities like that kind of spread through the day, they had like a fairly severe reduction in stimulus of their shaking responses. And so that's where I think one of the first times I connected with you was, did you see this research on Parkinson's, and that with the ticking response into Tourette syndrome, I'm seeing a kind of a correlation here where this is a neurological response. And if that neurological response is fatigued would it fire and build up and fire less? And the research that I've found on that seems to lend towards yes. But like you said earlier, there's not a ton of it. And I think the more, unfortunately, more people with Tourette's, those numbers are growing. But I think with the growth of that, the more research is going to be done on this. And I think that could be something that could be utilized for individuals to improve their quality of life in the long run. That may or may not end up with everybody, with a set of dumbbells in their house and a ski rig machine in the kitchen, where they could do some high intensity intervals a couple times a day. Yeah, right. But I don't know. I'd love to hear your feedback on that and get your thoughts on it, because quality of life naturally as we age becomes such a high priority. Dealing with a syndrome and or a disease now on top of it just makes things even harder. And any way that we can help on our end to improve that, we know is going to be well worth the investment. So
Absolutely.
What are your thoughts?
Yeah. So I have yet to see that study. I would love to dig through that. I'm constantly trying to find more of these studies, but even as you and I have conversations like this, if you get graduate students that are looking for their research projects, here's a bunch of ideas. Please.
Yeah. No kidding. Right. Yeah.
Right. No kidding. The more we can have these conversations, the more hopefully, little brain grapes that can grow to study this. I have so many ideas on how somebody could study. It hasn't even occurred to me to do it, to break it through the day. Mm-hmm. I kind of look at it as I would study breath work in kind of a breath apnea component. I would study eccentric antagonistic targeted training. That'll depend on the individual and their tic, mm-hmm. if it's a simple or complex, or if the tics keep changing, because that can happen too. They can be widely variable. Yes. Okay. They can be consistent throughout the years. They can disappear. It's a very obscure pattern of how they come out, and that really based on the individual. But targeted antagonistic strength training, tic dependent, breath apnea training, or some kind of threshold training like the ski erg. And for people that don't know what a ski erg is, it's this tall machine with two handles that you pull down and kind of mimic as if you have your ski poles and you're pushing down. Great machine. Absolutely love it. But to do some kind of overall fatiguing that is helps you get into a regulatory state afterwards. So does parasympathetic dominant state help? Does breath work help? Does soft tissue help? Because I think the community by and large is really fatigued and burnt out on being told, take a deep breath, relax. We need the physical components that kind of make you relax. When you do fatigue, not to a point of overtraining, but when you do really targeted mindful training that does fatigue you appropriately so that you can periodize and come back from it, what happens? I like to separate the categories on looking kind of as for bumbling my words here, a success to help with somebody's quality of life would look at reducing the tic urge itself. That would be the best, or reducing the intensity of the tic. If somebody's a really explosive ticker, maybe they still tic, but it's not as explosive.
Gotcha.
Or reducing the frequency of the tic, which helps minimize wear and tear.
I want to ask you about eccentric in a second, and just what your experience has been with that. But first question, we will work with individuals that struggle to sleep at night. And when we talk to them, we realize they don't exercise. They don't eat well. They don't have the greatest cognitive health, meaning they're not doing enough throughout the day to create a stimulus mentally to make their mind go, man, I need to shut it down. But then they nap through the day. And so they're basically at this low hum at all points. And at no point do they elevate to this high intensity scream or frequency that they would have to then rebound and come down from. And so by introducing in just any kind of exercise, resistance training, and or what we like to do is rucking. It's a loaded walking. You put on a backpack or a weighted vest and you just go do your regular walk. And the extra load being carried produces a greater stress response on your bones and your muscles, your cardiovascular system, et cetera. And then ask people to do those, either lifting or rucking with a partner or with a group. So now you have a cognitive stimulus and engagement. So now we're training our bones, our muscles, and our mind. we're stressing them to a high point with a stimulus of talking to our partners, but also stressing ourselves through a high level of effort. Then we're exhausted, and then we fight off the urge to allow our brains to go completely numb and or fall asleep, taking a nap through the day. So when nighttime comes, your body is ready to shut down because it earned it. And so my question is do you see a response with individuals with Tourette syndrome if you say, number one, I don't want you to have like down lulls in the day, but if we were to really stress you with a response of exercise 1-2 times a day, depending on what they could handle, will that help them in less tick response or less violent response, as you said, or do they have their tick responses while they're sleeping, and does that disrupt their sleep? And would the exercise then help them have less disrupted sleep better quality at night?
Boy, you totally get it. You like hit the nail on the head. Lack of sleep is a major trigger for people. It's not been reported very often that people tick during their sleep. It's possible that some do, but there's a huge incidence. Up to 80% of people have sleep disturbances with tick disorders.
So most people don't tick when they're asleep?
From what I have heard,
wow,
no.
That's fascinating.
It's right. It's a very intriguing.
It's got to be something with like lucid cognitive engagement that's causing the tick. They
believe it coming from the basal ganglia. That's basically the brain function that they believe it to come from. But different stressors, excitement, stress, lack of sleep, those are all very common tick triggers. We did an episode with a sleep specialist who it was really great conversation of basically just how to improve our sleep. And he himself had tics too. And but anecdotally, yes. Anecdotally, people have reported that exercise helps.
Okay.
The few studies that exist on exercise, yes, it helps. Okay. Like my quest is why? What and how do we get more help on hopefully reducing kind of this crossover between whatever this category of strength training will be and CBIT? Can we create some sort of a strength program that needs to be highly individualized or customizable for this, the 1.4 people that have been diagnosed with tics, and they think, 50% are not diagnosed. I don't know if I have that statistic correctly, but there's a huge population that goes undiagnosed.
Yeah.
And so how can we make some sort of protocol for an individualized experience that will help? And can we make it evidence-based?
Yeah. A place to start on their road back to quote unquote recovery, like, or
absolutely. Yeah.
So follow up on the sleep one. When you exercise really close to attempting to sleep, like your hormonal and basically all the chemical release of your body, the hormonal release of your body usually stimulates people up really good post exercise. That's the runner's high, the lifter high. Would that be of detriment now because you're attempting to go to sleep? You just exercise because you want to try to nullify your tick or the severity of your tick, and now trying to go to sleep, would that be maybe a lesser effective approach versus that exercise earlier in the day and allowing things to continue to fatigue, thus making you like really exhausted at the end of the day? Have you tried experimenting with either of those, or maybe anecdotally any of your clients exercise in the evenings or right before bed? Do they feel any more or less?
That's a great question. I would put that out to the community here. Anybody listening, chime in. I want to know. I don't know. I think when people exercise is kind of just a result of when they can squeeze it in their day.
Gotcha.
I know for me, if I exercise past 2 p.m., I'm still a little amped up.
Oh yeah.
That's for me personally, with tics. But I met a guy who actually did, I'm not as well versed on this at the moment, but there's a deep brain stimulation that they can do that they're trying to help the really, really severe cases. And that's what you think of from cinema, when people are, screaming bad words, which is called coprolalia, which is a really low incidence of people with TS. But these really extreme cases, I met a guy who did this, and he actually told me that working out helped him more. So anecdotally, there's a really strong case to pursue this.
And you just talked about like the profanity and the blurt outs and all that. Isn't
Mhm.
that like less than 7% or 9% or something
You're
like that? It's really
correct.
low, right? Okay.
It's very cool to hear that you know that you've
I mean,
yes.
that's when you say Tourette's to someone, they all go, "Oh, even fucking," and they just start blurting out, and they're like, "That's the only way they know Tourette's is from that." Because
Unfortunately, yes.
yeah,
And so
Seinfeld and everything else has, done an episode to kind of tease it, and that's how everyone's introduced to it.
that's how everyone's introduced to it, and
Yeah.
it's so wildly different. That's such a low percentage, but I
Mm,
appreciate you bringing that up because, yeah,
absolutely.
that's kind of the stigma that, advocacy groups are really working hard to change.
Yeah.
So part of the podcast too is to speak the language of movement,
Hmm.
involuntarily, voluntarily, and see how we can cross bridge this. So I think that kind of leads into kind of an eccentric conversation
Yeah.
here.
Yeah. Great.
I
Great.
gave a
Great segue.
I gave a presentation at the National Tourette Association conference back in 2024. Basically, like, how do I explain this? I got to make sure that this group knows how to talk to this group. So basically, I laid out in an hour the entire spectrum of training,
Mm.
variables, different muscle contraction types, kinetic chains, and then did it with a Tourette filter. Here's how Tourette training would fit into that. Here's how we could adapt for this. Here's how we could adapt for that. And I think kettlebells helped me tremendously.
Hmm.
There's a lot of weird co-contractions that happen. I have tics, had them since I was 5. They've gone down over the years, and it's impossible to say whether I'm part of the 30% where they naturally subside, or whether it's the result of me practicing this daily since I'm in high school. That was
Mm.
20 years ago.
Yeah.
It's impossible to say, but I strongly believe there's a little bit of both. But I'm losing my train of thought here.
Well,
Please.
let me jump in.
Yeah.
I have a couple of questions now because you got my brain going. I love
love it.
kettlebells as well. And let me start the question by asking or by saying that for all the listening audience too that doesn't like speak fitness dorky like I do, eccentric stretching is the muscle being placed on a stretch as it is pulled apart. So if you're squatting, your quads are going to eccentrically stretch as you squat down, and then they're going to concentric shorten as you stand back up. The muscles on the front side of your body, anterior, versus the muscles on the back side of your body, posterior, for the most of them are made up of different firing stimuluses. The posterior side of the body, in typical type 2 fibering, how fast a muscle can turn on or off. The backside is typically more dynamic. And so when you bring up kettlebells, the majority of kettlebell lifting comes from a hip hinge where you would clean or snatch or hoist the weight up into a high pull or into a goblet squat. You're continually using the posterior side of your body to initiate the majority of the movements when you work with kettlebells. And so my question is, have you had such great success with that? And would you feel that the posterior side, the back side of your body, is stronger than the anterior side, the front side of your body, due to your kettlebell strength training? And would that eccentrically give you a greater stress response, ultimately allowing you to, as we've been talking about, the fatigue response, less tick, less pain, better quality of life, etc.? Would that be an approach that you would maybe suggest in with folks to practice on a regular basis? Because you're not going to lay down and bench press. You're not going to do a bunch of bicep curls, right? You're not doing crunches and sit-ups with kettlebells. You're doing some full body strength training, but the majority of that comes from the backside of your body. Would you agree with that up to that point?
100%.
And would you feel like that's been a big success to your ability to manage and improve your quality of life?
100%.
So if we were to kind of take that one level more, where would we implement this with, let's say, a brand new individual that's coming in and they're like, I don't understand anything you just said.
Yeah.
But what do I need to do to start to improve here? This is kind of like you were mentioning earlier, like what would the protocol be, to kind of build in? How would you start to kind of implement, like what are a couple of the lifts that you would really focus on with a brand new individual coming in with an eccentric emphasis on getting them to feel this response, this return right away?
So my kind of training philosophy with anybody, whether it's tics or not, I've trained people from ages 12 all the way up to 92, and some with tics, most with not. But it's a gear analogy. Like, we've got to tinker with the body first, and this is where I do think some single joint work is beneficial, especially for the ticking community, to figure out, can you turn on this muscle and connect to this part of your body that we want to? No, why not? Is there a restriction? Do we do soft tissue work? Do we do mobility? So that's all the gears that we have to figure out. The soft tissue gears versus the tinkering, movement, activation, mobility gears. And that takes time in the beginning, but as we slowly start to get those together, then it all starts to play together. So in the beginning, we got to do some of the soft tissue work. We've got to do some of the boring shoulder external rotations, because if you're a forward shoulder protractor and internal rotator, have you ever even felt this muscle click on when you do external rotation? That does something to the brain. There's a sensory component there. And so then as those gears start to come together, then we start to introduce some of the lifts. Then we get a stick on their back and teach a hip hinge. I have found, I love the serratus anterior. It's my favorite muscle. And, as I've had some people with neck tics really try to work on supporting their whole shoulder complex and figure out all the different pieces here. A lot of times when we do like a serratus push-up, protraction, retraction, a lot of the time, and this is just a correlative observation, one of their quads has fully spasmed. And that's happened with a lot of people. So that's where I'm thinking, okay, so this protraction and this other co-contracting muscle, this is where the gears have to come in. And here's where we get to start making more educated exercise selection for that individual.
And there just hasn't been any research on this.
No.
Wow, man.
No.
what a underserviced community. You said
especially
something,
the older population too, because it's thought of as a youth syndrome.
A youth syndrome.
Yeah.
When you say that the ticking community, that's an acceptable term. That's not.
Yes.
I'm not saying anything wrong by that.
No,
Okay.
Not at all. The ticking community, tickers. I've adapted to calling my listeners movers. I move, you move, we all move. I'm Greek, so I can bring it.
Love it. I love it.
Yes, but no, absolutely. You can call it the ticky community.
Community. Okay. And I'm actually kind of like shocked / appalled that there hasn't been more done for this community, because there's a large number of people affected by this. Yes. And this deserves an area of focus like that, to have a protocol that would like a way to look at this as a systematic approach of, here is your syndrome, and here's a 4-step, 5-step, process to kind of introduce this. Because like you're talking about, we would take let's just call it like a regular 65-year-old person with minimal physical limitations. And you could just say, like, go in and get on the machines and do chest press and seated row and leg press and pull downs, and you pretty much cover everything. What you're talking about here is the millions of repetitions that have been done on one joint versus not the other. These are involuntary. They're done at high speeds. They're done spastically, uncontrollably. And so many times, like any kind of itis, bursitis, tendonitis, any of these are overuse injuries. And you are selecting typically to make those movements, and we still get these overuse itis injuries. So if you had musculatures that were just firing all the time without your desire, your will to do that, those injuries are going to flare and equate even more. So here come all of your imbalances. Here comes your asymmetries, like we started talking about in the beginning with scoliosis and the asymmetries. Here come all of those. I mean, this is a much more in-depth design of a protocol than just go pick your favorite 5 machines inside and push and pull and press your way into some basic strength training. I think forgive me if you've done this, but I think there's something to be designed here, much like we've done with TOA in building a certification, more or less, to help coaches learn how to do this. We have another coach that I work with and I mentor, Jen Lesendorf, who works with individuals with Parkinson's and has built this great program with a combination of boxing and resistance training to help all of her Parkinson's clients really improve their quality of life, to the point where she's going to now produce some variation of kind of a progressive course or instruction to help other coaches learn how to do this. as you continue to develop this, I encourage you, again, forgive me if you've already done something along this, I encourage you to track this and record your progresses as you continue to build your philosophies and your strategies with this, and then share it, with other people, however that might be, in a book or in a workbook or in a regular podcast like you're doing now, or in a certification at some point, because this is a very underserved community, and this is only going to be something that people, unfortunately, are going to have to seek out help with dealing with. And if trainers are armed with that information, I'm assuming you're the only one in your field that is talking about this specifically like we are right now. You're the only one I know of
at this point.
Yeah.
There might be more of us. Come talk to me, email me if you're out there.
Yeah.
There might be a handful more, but I appreciate that. I have done some programming. It's in its infancy at tickfit.org. I have a wrist tick program where we work on like centrating joints. That's what all of the programs are based on. First and foremost, if we talk about the gear analogy, how do you centrate a joint? Because that's going to guide us with what direction your body needs to go.
And what do you mean by that?
So like a wrist tick, a very common one is a flexion of the wrist here.
Okay.
Sometimes it's rotational, but I mean, the shoulder is going to go along for the ride too. So we do a lot of quadruped movement. We make sure, there's a flat hand, that you're pressing through the L, that the eye of your elbow, your shoulder's externally rotated. And maybe we do some feedback with the ball. Maybe we do some bear crawls. And then most of the programs are designed to graduate to kettlebell work.
Gotcha.
Is with kettlebells too,
Okay,
if you do an arm bar, there's no wrists in kettlebell, right?
Yeah.
You can't have a floppy wrist. That's not part of that program. But how do you centrate whatever joint? There's other really common tics, like back twisting tics, where you twist backwards. And again, what's the sensation driving it? Is it a contraction of the QL, or is it, an eccentric sensation on your TFL? And so things like that, we would teach them hinging. We'd go bilateral before we go unilateral. We would work on split stance. We'd, graduate into things and then work towards a two-handed clean. And that's kind of how they're all designed.
Very good.
But as I'm going through this, I'm thinking, oh my gosh, there's infinite amount of tics. What if my programs don't work for people? Let's do the podcast. Let's get everybody on here. And then I can now have a network and resource for people to go to that know more about Tourette and other tic disorders.
And
you're
even
part of it now.
Yeah. Oh, and I'm happy to be. I love chatting about this, but I also love learning about it, because it gets my brain going on, like how else can we contribute to this? As I mentioned, Jen, before, with Parkinson's, she tells me you'll meet 100 people with Parkinson's and you'll see 100 different forms of that disease.
Right.
Would it be similar with Tourette's? Like, you're not going to find two people who have the exact same
correct
tics or response. So are there, shift this to me interviewing you, are there medications? Are there different things that people can use that, like, I don't know, like it dulls your sensation to produce the tic without dulling your mind?
There's no Tourette pill. There's no Tourette pill, but they use a bunch of different. We did a couple episodes with some occupational therapists that dove into that a little bit more. But yeah, there's no Tourette pill. They use it.
If you give somebody a muscle relaxer or something, would that produce any kind of less? But it slows everything, right?
Right.
So
that's helped me a little bit. If I've been in this really like heightened gripping state, it has. But then at the same point, you're talking about quality of life, and then everything's subdued.
You're in a zombie state. Yeah.
Right.
For those that haven't done muscle relaxers, have you ever taken like Benadryl before? If you're a full-size person and you take 2 Benadryl, like, you're out for the next 2 days. You can't think straight. You're cloudy. You just can't. Your body just doesn't want to do anything. Like, it suppresses your system so much. That's the same as most muscle relaxers you'll get out there. You don't take it and say, just shoulder relax, like everything goes, and injury rates are very high when you do it too, because all your joint stability, all your little musculatures and everything else in the joint, they're all relaxing as well. So it actually causes more harm than good in many cases if people try to utilize a muscle relaxer and try to exercise or be active at the same time. Like, man, okay, so you can't do a targeted medication. I don't know, like, just fascinating, yet at the same time frustrating not to be able to find something that really gives people a lot of relief other than the benefits of exercise. And that's where it seems like most research points to. So what would, go ahead.
Sorry, go ahead. Question on
the aging adult, you
Yeah.
mentioned kind of the big three. Like,
Mm.
what are big things that just happen with age naturally that the gym can help with?
The foundation of our program is built around movements that people would perform on their daily basis. So there's something called
ADLs.
there's something called ADLs, activities of daily living, and these come down to dressing, toileting, shower and bathing, clothing yourself, transferring around the house, really, really basics. Beyond that, we have another one called daily life function, DLFs. And this would be ascending and descending stairs, sitting to a seated position, standing back up, getting up and down off the floor, being able to pick something up off the ground, being able to press something over your head, and then carrying heavy loads. And so those are kind of the primary movement patterns that we start to focus on, because that's what most people do. General locomotion is your first movement pattern you do the most every day. That's just kind of walking about. Outside of that, the average person will do about 100 hip hinges per day during their 16 or so hours of wake, which puts you right around 16, 17 hinges per hour that were you're going to be performing this. So, or excuse me, 6 to 7 hinges per hour that you're going to be performing these. So a basic hip hinge, hinging at the hip to pick up your shoes or your purse or anything, all the way to picking up weights. We'll do about 6 or 7, maybe 8 of those every hour on average. At the same time, whenever we hip hinge, we typically grab something, groceries or a bag or your laundry or whatever it is, and then you bring it towards your body and or down to your sides, and then you transfer it somewhere else, and you put the laundry basket back, or you put the cupboard in the thing, you put the dishes and this guy, you carry your groceries in from the car into the door, you put all the weights into your left hand so you can use your right hand to open the car door, the house door, and then you come in and you go around the dog and you go around the island in the house, and you hoist them up and you put them up on the countertop. And so we look at all that and we're like, well, we just did a transfer, and we just did a carry, and then we just did a row, and we just did a deadlift, and then we did a high pull. And so we kind of look at all that and we go, well, what are those movement patterns like every day? And we go, well, let's do sit to stands, and let's do lots of those. Let's get people really good at those. So that's big three. Number one, sit to stand. Number two is row, posterior chain. We talked about the value of that, pulling something towards you or over your head, pulling it down like a simulated chin up or just any horizontal row. That's big three, number two. And then the third one is just pick up heavy weights and carry them around. However it is, even weight, uneven weight, one weight, to two weights, a suitcase carry or a farmer carry, walking around with load in hand, braced. Well, we don't call them a farmer walk. I call them a farmer carry, because you're not just waddling, walking around. You're braced. You're locked down, and you're carrying this weight, right, with an intention. And that's big three, number three. If we can sit to stand, if we can row, and if we can carry, and do that on a regular basis 2-3 times a week, we see that's going to have the best return for our clients, our people practicing on a regular basis, to really improve their quality of life with a pretty minimal time investment, 20 minutes, maybe every other day. And so that's our base entry program. It's called EOD 20, every other day for 20 minutes. And if they can hit those three, they should see really good improvements.
Simple and effective.
Absolutely.
And applicable.
Easy. I mean, it's easy to say, I'm going to spend the next 20 minutes and focus on this. And we teach them a little 5 to 6 minute warm up, and then a 3 to 4 minute cool down. And there's a full 30-minute time investment. But time that you're actually like, I'm on the clock, I'm going to start resistance training now. We would love to see about 20 minutes every other day of doing that. And it doesn't have to be anything overly fancy. It just needs to be of a heavy enough load to produce a stimulus. And you'll see things on t-shirts all the time. If it doesn't challenge you, it doesn't change you. Like, that kind of mentality is pretty true. If you grab something and you pull it towards you and you let it go, and then you pull it towards you and let it go, and you do that 10 times, and you don't really feel a huge challenge, you don't feel any muscles burning, and you don't feel like you're having to breathe a little bit heavier, you're in that kind of zone 2, huffy puffy a little bit, it's not challenging you. So that's not going to change you. So you need to up those loads. And I think one of the biggest misconceptions we have with aging bodies is, if we lift too heavy, we're going to get hurt. And to the point is, if you never resistance train and then you try to lift something too heavy, you're going to get hurt. That's accurate. But if you resistance train on the regular basis and you lift heavy things, you're going to live a long, happy life. Like, that's basically what we kind of narrow it down to, is that you're really not going to have any problems if you're nice and strong. And all of the research out there, which is a significant amount at this point, shows us that the older we are and the more muscle mass we have, the longer we live, the happier we live and the more cognitively aware we are. And those are 5 key things that I want people to be able to continue to do in their aging process. And it all funnels down to the base foundation, which all this is built on, is about 20 minutes of resistance training every other day.
You know, we talk a lot about neuroplasticity too. Like the body can learn these new things. Like you said, you don't go from not doing anything to lifting heavy. There's progressive overload and there's consistency.
Absolutely. And as with any other skill, like you would need to learn the basics and progress accordingly. But this can be done at any age. And we've seen research studies. There's a great, I think the Washington Post put out a study last year that was done right around December, early December. And it talked about 18 to 25-year-olds, resistance training, improved muscle mass, bone density, everything we've been talking about. 30 to 35-year-olds, same result. 50 to 55-year-olds, same result. 70 to 75-year-olds, same result. 85 to 90-year-olds, same result. So across the board, no matter what age they were at, resistance training works, and it can help you improve at any point. It's never too late.
I love that. I got to say, carries were a really big change for me, both in learning about intra-abdominal pressure. I still had a lot of abdominal tics, and I actually have a grade 2 spondy in my spine too, which is typically seen in the older population.
Yeah.
And
you're right there with me having that little shared experience of what it's like to be an older adult, huh?
Man, just a fraction of what you've gone through. But yeah, I do have a grade 2 spondy, and it's something that I have to work on every day. I have yet to have surgery on it. My hips coming up next. Hip mobility is on my right side is part of my daily life. And to be able to do these things when I'm in my 80s, that I can get down on the floor. And it starts now. I'm approaching 40 here in a couple months, and there's still a lot of time left in this body.
Yeah, I would hope to say you're not even midlife, right? I'm hoping you get to 100, and if not more.
Here's hoping. The centurion.
And exactly, and that's where I was going with Peter Attia, and he talks about the centurion, sentinel athlete. He talks often about if you are going to be amazing and be in good shape at 80, it has to start in your 50s. And if you want to be great in your 50s, it has to start in your 30s. Like this is a common practice. You can't just wait until you're 65 and then go, well, I guess it's time for me to start getting in shape. You can, it's never too late, like we talked about. But if you have a full, lifetime of work, a whole body of work here, literally a lifetime body of work that you've just gradually kept strong, the reduction in poor posture, cognitive decline, all the way down to like sleep performance, sport performance, and pain in any and all joints, your postural awareness, your balance, your coordination, all across the board, like all these things that we just kind of take for granted every day. When you are stronger and more well-conditioned, all of those are performing at higher levels. And that's something that I hope everybody kind of takes away, is that just like you just said, your late 30s, whatnot, you just said, if you want to be amazing at 50, the work you're doing now is going to make that happen. And as you continue to do this at 50, it's going to set you up to be great at 70. The mindset is this is you now. You resistance train every other day for a minimum 20 minutes. And then on your other days, you're active, whatever you want to go and do. Our goal is 225 minutes of activity every week, which breaks down to about 32 minutes every day. And there aren't days off. Like that's the goal, is that every day you should be physically active, whatever it is. So you could resistance train Monday, Wednesday, Friday, and then you could ruck on Tuesdays and Thursdays, and you could golf on Saturdays and go swimming or bike ride on Sundays. And as long as you're out there for 32 minutes or so on, we're going to be in relatively good health and shape. And that's where I would encourage everybody to look at this and say, okay, if I really want to make a big change in my life and I want to start to improve myself despite any syndromes, any disease, etc., start off by adding 20 minutes of something every day. And take those baby steps up to get to 30, 32, 35 minutes or more. You can always do more, but just do so accordingly to where Peter T also talks about get as strong as you can for as long as you can and avoid injury at all costs. So if you progress accordingly, these proper baby steps over months and build up, you'll avoid injury opportunities very, very well. And that ultimately will help you in your aging process and your pursuit of strength gain as you continue to be an aging individual.
That is sage advice from a very educated and experienced individual.
Oh, man, he's one of my favorite human beings. I absolutely love him. I love that we have a medical doctor that can stand on the front lines and tell people, along with Dr. Huberman and Dr. Andy Galpin and Dr.
Yep.
Stacy Sims and Belinda Beck and Gabrielle Lyon. Like, we've got all these doctors now that are getting up there and telling everybody, you got to have muscle mass. You got to work on your bone density. You got to be active every day. And it's so great because for a long time, the medical industry was battling against us and telling us, don't exercise. You're going to get hurt. Just take medication.
Here's your weight limitation. Don't lift more than 20 pounds. Yeah.
And we still see that quite a bit, but not as much as we did 5 years ago. And so things are definitely improving, but we've got a really great community of people who are preaching all the right things right now. And I hope everybody gets to hear it and take it to heart.
Yeah. And I hope the Tourette community is part of that conversation now too. I think in studying how exercise affects this syndrome, and as of now, there's no cure for it. But again, a reduction in tic urge intensity or frequency can lead to less pain, and less pain is a better quality of life. So
100%.
Hopefully there's a lot to learn just about the human condition when we study the benefits of exercise with this syndrome.
Absolutely.
Robert, where can people find you?
My name, Robert Linkul. I'm on Instagram, on Facebook. We also have our TOA, trainingtheolderadult.com website. We have TOA on Instagram, TOA on Facebook. I have a YouTube channel. I've got 400 and something videos on there.
Great info.
At least one new one every week. We put up there all free. And I, ramble and rant about all kinds of different stuff, and have a pretty good time doing that. I try to do a little bit of stand up and some jokes and some dumb dad jokes as we go through and all that, and have a good time. Make it as entertaining as I can so people can really retain the information. They can remember the stories or remember the dumb joke and go, oh, that actually really makes a lot of sense. And so we try to teach and educate with some good stories and some humor to really help people retain it. But yeah, the whole intention is to spread this word. Instagram, Facebook, YouTube, our website. We try to spread the word as much as we can and educate as many as we can with this pure intensity of combating sarcopenia.
We will put all those in the show notes. I can't thank you enough, Robert. I hope this conversation, honestly, kind of one of the first of its kind. I've never heard this in depth of a conversation, and every podcast I've done so far, it's kind of been a new branch to hopefully what will lead to some new research.
Nice.
to help people.
So. Yeah, I sure hope so. Like you said, hopefully there's a bunch of college kids out there going, let's do kettlebell swings and see how it affects the Tourette syndrome. You know what I mean? Like, that'd be cool. And we start getting more out there. Man, that would help. That would help a lot. Yeah.
Big time.
Definitely underserved community. I hope this reaches and gets into somebody's mind out there that can help this in the future. So yeah, it was my pleasure. Happy to chat. Always happy to do it again. Thank you for reaching out. And it was truly a pleasure to get to chat with you.
Awesome. Thank you, Robert. I appreciate it.
My pleasure. Thank you. Bye, everyone.
Bye.
We love providing a platform for sharing ideas about living with Tourette syndrome and other tic disorders. While we strive to keep the content evidence-based, please understand that exercise science, information about Tourette syndrome, and its co-occurring conditions are constantly evolving. The content shared in this podcast are for informational purposes only and should not be considered medical advice. By listening to this podcast, you agree to not use the information as a substitute for professional medical advice or treatment for yourself or your child. As always, consult your healthcare provider before making any medical decisions or starting any treatments related to Tourette syndrome or other health conditions, which also includes mental health. This disclaimer also applies to any guests or contributors to the podcast. TicFit and the podcast team do not take any responsibility for any actions taken based on the information provided. Our goal is to educate, support, and raise awareness, not to diagnose or treat any medical condition. Thanks for listening.